Hello and welcome to everyone. I'm Ernest Choy from Cardiff University. It's my pleasure to chair this evening's ForumLIVE. And I'm really excited to welcome two outstanding speakers during this evening's discussion. First of all, Professor Chris Edwards from the University Hospital of Southampton, and also Professor Rieke Alten from the Schiss Park Clinic from the University Medicine Berlin. And they're going to discuss with all of us tonight about the role of Janus kinase inhibitor in the treatment algorithm. So a couple of housekeeping items before we start this evening's ForumLIVE. Everybody will be put on mute during the duration of this meeting. If you have any questions for the speakers, I'd like to encourage you to submit this at any time through the Q&A function at the bottom of your screen. But if you have any technical difficulty during the webcast, then please use the chat box and the technical team will get in touch with you to resolve your issues. So this is the agenda. After this very brief welcome and introduction, Professor Chris Edwards will start off this evening's discussion by talking to us about the use of JAK inhibitors as the first advanced therapy as well as post-biologic. After that, Professor Rieke Alten will discuss with us the real-world data on the use of JAK inhibitors, similarities and difference in different countries. At the end of those two talks, we will have a panel discussion when we will take all your questions and hopefully provide you with a helpful answer. So without further ado, I'd like to introduce to you Professor Chris Edwards, who is well known to many of you. He is a clinical researcher and investigator and is a professor of rheumatology at University Hospital Southampton. Over to you, Chris.
Thank you very much, Ernest, and it's a real pleasure to take part in this webinar and to be joined by my colleagues, Professor Choy and Professor Alten. Always fun to spend time with you thinking about rheumatoid arthritis and treatment of our patients. So I'm going to spend a little bit of time thinking about some of the data that already exists, but how that then fits with our decision-making around use of JAK inhibitors, either as the first advanced therapy, so when conventional synthetic DMARDs have failed, or after a biological therapy. And I guess to do that, there are bits of information we need. I'm going to show you a little bit of the trial data. And then we need to weigh that, of course. It's weighing risk and benefit against some of the thoughts around safety at the moment, which help us to make that decision. And then Rieke will go on, I think, to look at real world evidence for efficacy as well. And hopefully we can pull that all together in the discussion. Okay, so here are my disclosures. And I thought I'd start by just thinking, so what's the question we're asking? And when I saw the title, I thought, well, we're trying to decide where we use JAK inhibitors, whether we use those as the first advanced therapy or whether we use them after biological therapies. And we're looking at the evidence in terms of efficacy and also safety to try and weigh that. And it's always worth thinking back to a case and imagining a patient we might see. So this is a made up case, but hopefully it makes the point. So 43-year-old woman with rheumatoid arthritis. She's fit and well, no comorbidities, but has poor prognostic factors for rheumatoid, so likely to do badly, strongly positive for rheumatoid factor and anti-CCP. And gets to the point where she's failed methotrexate and also failed sulfasalazine for a number of causes. And with that situation, what's the information you'd need to know to make a decision about whether you use a biologic next or whether you use a JAK inhibitor next? And then if we change that, and the thing about cases like this is you can play with them, can't you? You can alter the relative levels of risk and benefit, and it can help as sort of a mind experiment to try and decide, okay, so what would I do now? So you might have said, okay, I'll use a biologic because I've been using those for a long time in that patient. But actually she doesn't like injections. I might use a JAK inhibitor in that context. But then over on the right-hand side, we say but what if she also had a DVT? And what if she had cardiovascular comorbidities and risk factors for malignancy as well? Would that change you? And then of course you can keep changing. what else might change the decision you make? What if the disease was really, really active and was very rapidly progressive and causing damage in her joints? How would that alter the order? But to make these decisions, you have to know what's the evidence for efficacy and what's the evidence for safety. Whoops. Okay, so when we're looking at any therapy and trying to decide whether it's effective and trying to make decisions about when to use it, we want to know what it does. And of course, for therapies to treat rheumatoid arthritis, we start off wanting to know about disease activity. Okay, so we can look at some of that. We want it to be disease modifying, so we look at joint damage. And also increasingly on trials, there's more and more at the bottom, which are all these patient-reported outcomes, and particularly pain has been of interest in relation to JAK inhibitors as well. And you could add other things that you might be interested in that you could pull out from data, both from trials and also from real-world evidence. But it comes back to this weighing up of risk and benefit, doesn't it? So if you look on the left-hand side, if you were looking at a new therapy, in this context, we're thinking about JAK inhibitors, and we want to know that it works in the CS-DMARD inadequate responder group, so people who failed methotrexate or sulfasalazine, just like the case I showed you. We might want to know that it works in the biologic DMARD inadequate responder population. We want it to be disease modifying, and we want it to make people's lives better and have positive effects on PROs. And then on the risk side, we want to know that the risk is at least as good as what we already have. And if not, we're going to start trying to weigh the relative benefit of the efficacy versus the risk. Okay, so here's JAK inhibitors, and just to introduce the class, you know all the background to this, so I won't say much, but an oral therapy, that's different, isn't it? Short half-lives, that's different, and a way of having multiple effects on multiple different cytokines and growth factors simultaneously, rather than blocking one cell type or one particular cytokine. The other thing to say is when we're trying to make these decisions, the discussion we're having tonight is very much around the current situation and where we are on the development of a therapy. And this is just to stimulate thought about where we are in relation to JAK. So if you look over on the left-hand side with any new drug, there's the drug discovery in the lab, just a few people get excited, early phase studies, a few more. And then people have described it as peak hyperbole when the phase 3 studies come out and everybody's very excited. And then, of course, we have a dose of real life, which comes as we get into long-term extension studies and real-world evidence. And that allows us to see where exactly the drug fits, and we start to learn something about adverse events and how we mitigate about some of those risks as well. And you can see where we are in relation to JAKs on that timeline. Okay, so here are the 4 JAK inhibitors, left-hand side. I've mentioned short half-life. There are some differences in excretion and the relative degree of JAK specificity. I don't think we need to spend much time on that. But these are all available. And I guess our experience with these will depend a bit where we work. So where I work, I've used more baricitinib and more upadacitinib. Tofacitinib came later, and we're using a little bit of filgotinib. And you will have different experiences where you work, depending often on the order with which these drugs became available. Now, I mentioned to be able to use a drug and to be able to use JAK inhibitors, there's information we need. And I'm not going to go through all this data. Just here's a summary of the phase 3 trial program for tofacitinib, baricitinib, filgotinib, and upadacitinib, and those studies that are mentioned. But I've highlighted, first of all, there is data around the methotrexate inadequate responder population and the CS-DMARD inadequate responder population. You can see that across the names of those trials. And at the bottom, there's also information around the biologic DMARD inadequate responder population. And you can show that sort of information with a summary. So I could show you all the individual studies, but this is from a review. And if you look along the top, we've got tofacitinib, then baricitinib, then upadacitinib, then filgotinib. And we can look at the methotrexate inadequate responder population in the top line. And then in the bottom line, we've got the biologic DMARD inadequate responders. And there's no statistics on here, but you can just look at the JAK is always in black. And the control group, which the placebo group, which is usually methotrexate on its own, is in the white. And if you scan across ACR 20, 50, 70, you can see the obvious statistical test of a difference in these bars across these different statistical endpoints. So this demonstration of efficacy in a whole number of trials, both for biologic inadequate responder patients and methotrexate in adequate responder patients. But we could go further, because we're also in the luxurious situation of being able to have head-to-head studies against a TNF inhibitor. In this case, it's always adalimumab. And as we work our way across, you can see for tofacitinib, for baricitinib, for filgotinib, and for upadacitinib, these studies exist and allow us, if we were trying to make that decision on efficacy, to say, are they as good? Are they any better? And you will have seen this data, I'm sure, but here is a summary around this. So if we look across these 4 famous studies, you can see the primary endpoints are a little bit different. Usually for rheumatoid studies, ACR 20 at week 12 is used, but you can see for upadacitinib, for the EMA area, for the European area, remission according to DAS 28 was thrown in as well. I think that was interesting. And then there's various different statistical endpoints that were predetermined. And either for tofacitinib and for filgotinib, non-inferiority was shown against adalimumab, and for baricitinib, for the endpoint shown, and upadacitinib, for the endpoint shown, superiority was shown. So you'd say at least as good. If you're optimistic, there's some evidential support for saying a bit better for some of them, maybe. So that's thinking about efficacy, but of course, we're also weighing this against risk as well, and that's always in our mind. And there are a few things we have to think about. I suppose one of the things that's become clearer over the COVID era is this idea that uncontrolled rheumatoid has its own problems. Now, we already knew about the comorbidities in terms of cardiovascular and the effects of systemic inflammation when it's not controlled, but uncontrolled rheumatoid arthritis leads to more infection as well, as we've seen in a number of different situations. But there are some inherent risks with rheumatoid. So there's sometimes the physical disability and reduced mobility. There's the immune dysfunction itself, and then there's the effect of comorbidities, whether that's cardiovascular, whether that's interstitial lung disease. And then when we're using therapies that modulate the immune system, we're always worried about infections. We screen for TB, don't we, for TNF inhibitors. Zoster's a bit of a signal with JAK inhibitors, and we're always looking for malignancies, and we're looking for cardiovascular risk. And some of those have become more into focus, particularly in light of the oral surveillance studies. So you'll remember there was a little bit of data around thromboembolic events, and as a result of those, a little bit of care was taken. But then oral surveillance has resulted in us thinking a bit more deeply. Now, oral surveillance you will have seen, but I thought I'd touch on a couple of things. So this was an FDA required study, large number of patients, and you can't trivialize the results because it's a well done and well organized study. Worth saying that it's a relative risk. So it's the relative risk of tofacitinib against a TNF inhibitor. So it's not against a CSD-MARD on its own or a placebo group. It's relative to the TNF inhibitor. The other thing I think is useful is just to think on the top, you can see the hazard ratios for MACE and then for cancers, which showed that there was non-inferiority wasn't achieved for this particular study. So there were various statistical analyses done. And then I looked on the right-hand side. So I'm always interested to look at numbers needed to harm. And although I don't want to trivialize the risk that was showed in this study, you do have to treat quite a lot of patients with tofacitinib versus a TNF inhibitor to see adverse events. And you can see that shown on the top right-hand side there on the slide. The other thing I think is useful, along with other studies that look at this, is it helps you to decide the risk in your individual patient because it comes up with some things that make the risk more likely, and you can see smoking and aspirin use and greater age as well. So that comes back to the nitty-gritty practicalities of seeing a patient and trying to weigh up what you're going to do. But for tofacitinib, not all the data shows this. I think Professor Alten is going to show some real-world data around this as well. But here's tofacitinib and biologic DMARDs from a big database in the US, was called Corona for obvious reasons, now called Core Avitas. Thousands of people involved. And essentially, apart from showing zoster was higher than biologics when tofacitinib was used, actually for malignancies, for MACE, it was the same. The error bars cross over one or are right in the middle, so no difference. So, you know, we can't ignore oral surveillance, but not all the data points that way. Now, in terms of ordering of what we do, because that's what we think, can we use JAK inhibitors as the first advanced therapy versus after a biologic? Different regulatory authorities have taken different stances. So here's the FDA at the bottom. And essentially what the FDA have said is that you should use a TNF inhibitor first. Unless there's a really specific reason, that's what you should do. And you should do it for all JAK inhibitors, because although this data was for tofacitinib, we're worried about the whole class. That's their stance. The EMA is in a process at the moment where it's pulling together all the data, investigating it, and will come up later in the year, I think, with a view about this. But at the moment, the comment is around tofacitinib more specifically. And it says, you can do this, but you need to think about the risk and really be careful in relation to considering the risk before you use tofacitinib in people who are at higher risk. And that's had an influence on the thinking of rheumatologists across other organizations as well. So this isn't published formally yet, but it's been presented, and I think it's okay to show it. It was presented in EULAR in 2022. And this is the more recent update, or the ongoing update, of the EULAR recommendations for the treatment of rheumatoid, which has been submitted. It's with the journal at the moment. If you look at what the previous recommendation said, it said, if the treatment target is not achieved with the first CSD-MARD when poor prognostic factors are present, a biologic, the TSD-MARD, can be added. So it says they're the same. You can use them in the same order. And if you look over on the right-hand side, it's saying you might do this, but you really should consider risk factors. And I thought that was a very, reasonable and sensible consideration. And we'll come back to the risk factors in just a moment. So this is what you do. So this is, you get a patient with rheumatoid, you start them usually on methotrexate. If they don't respond, if they don't achieve the target you're aiming for, you get to this consideration point about, do I use a biologic? Do I use a JAK inhibitor? And it says, add a biologic DMARD and consider a JAK inhibitor only after risk assessment. That's what's been changed across all the class rather than just tofacitinib. And if you see in this box on the right-hand side, number 6, these are the risks, which I will zoom into to make it easier to see. So the following risk factors for cardiovascular events must be considered. And that's some of the things I already mentioned from oral surveillance: at greater age, smoking, other cardiovascular risks, malignancy, and then risk factors for thromboembolic disease. So it's saying you can do it, but think about it and be cautious in these higher risk people. Okay, and then the last thing I was going to show is a little bit of deviation into real world evidence. So I hope Professor Alten will forgive me for this, but I thought I'd say, well, what are we doing? So we're making this decision about when to use JAK inhibitors. Do we use a biologic? Do we use a JAK inhibitor when the CSD-MARD, the methotrexate, for example, has failed? And this is specific to baricitinib. This is data from the BSR Biologics Registry that was published, shown at the BSR, once again, is at manuscript level. And you can look and see the sort of percentage of individuals that have previously had a biologic before they get baricitinib in routine use within the UK. And it's the majority, it's about 2/3 have previously had a biologic. Talking to colleagues, looking at more individualized data that people have collected in their own hospitals, it really varies. In some places, I think in Southampton, we're closer to 85% have had a biologic, and I have colleagues, it's more like 50-50. So there is a variation, but this is overall what people are doing. Okay, so here's the summary. So JAK inhibitors as the first advanced therapy, well, the efficacy is there to support that, isn't it? There's efficacy after CSD-MARDs, there's efficacy in the biologic inadequate responder patient population as well. The safety signals, particularly oral surveillance, that's led to us reappraising this a bit. And so we get back to this period or in the development of a drug where we start to really get down to the hard risk benefit decision making before it then slots into routine use, which will probably happen in a few years' time when we've worked all of this out. And that's being reflected in recommendations. And it's always interesting. Partly this is timing, I think, about when these individual recommendations or guidelines come out, in how they're interpreted differently in different jurisdictions. And you can decide whether you think you support more the ACR approach or the EULAR support or your own particular view. And then, of course, I showed you a tiny bit of real-world data, hopefully as an introduction to what Rieke will show you. But real-world data is going to help with this as well. You know, those are not just trial patients that I've talked about to some extent. So thank you very much for your attention.
Thank you very much, Chris. That's a wonderful start to this evening's Forum Live and putting us in context with the efficacy and safety of Janus kinase inhibitor and updating us with the various guidance from regulators as well as international societies. So I think this is a great point to introduce Professor Rieke Alten, who is going to discuss with us the real-life use of JAK inhibitors. And I think she's going to tell us that our interpretation of the data from different countries is going to be slightly different. And Rieke has been author of many clinical trials, not only involving Janus kinase inhibitors, but also registries. She is professor of medicine as well as chief of rheumatology at the Schlossberg Spark Clinic from Berlin. So over to you, Rieke.
Ernest, thank you very much for the kind introduction. And I would also like to thank Chris for handing over already to this topic, because the real world data, I selected 3 specific lines, similarities and differences from the JAKpot study, which was recently published, but also the BeReal study, which we investigated, especially with baricitinib. And here I have mostly the data from the European cohort. And last but not least, observational data from our German rabbit register. And I think these data are really very interesting also. These are the disclosures in relation to this topic. And of course, all of you maybe have seen this publication. It is a large number of patients which have seen more than 30,000, because 19 registers all over the place have been contributed. And also our own register, and you see here Anja Strangfeld has contributed to this publication. The background is that patients with rheumatoid arthritis and an inadequate response to CSDMARDs, as we have heard before, have several second-line therapeutic options from which to choose. And the most actual discussion is really to choose to go to a JAK inhibitor or go to the old school TNF. We have seen some head-to-head trials, but these head-to-head trials cannot really give an answer to our burning questions. So we need to go to the registers, because there we have a unique opportunity to compare the available treatment options and understand the effectiveness of these therapies in the clinical situation. And here we have 4 compounds which were compared: the TNF inhibitors as a group, ABA as a single stand compound, IL-6, and as a whole group or a whole class, the JAK inhibitors. And here you see the methods. Over 30,000 patients were included, 30,000 treatment courses, 17,000 was TNF, 2,700 was ABA, nearly 4,000 was IL-6, and already, and I think this is important for the short time period we have the JAK inhibitors, nearly 8,000 already with JAK inhibitors. And the primary endpoint of this study was the drug discontinuation, which is the most important outcome really, which we have in real world trials. There were also secondary outcomes, the reason for discontinuation, which is very difficult to assess, but what they measured also is the clinical disease activity index for remission and for low disease activity. This is the flowchart of the patients which were included all together. And here we come already to the results. First of all, I would like to show you the efficacy results. And you can see, if you compare the 4 groups, it's very similar concerning low disease activity at month 12 from all the registers. And also, if you come to low disease activity, there is not a big differences between the 4 compared drug classes. So here you come to the different countries. And unfortunately, I talked to our register. We have no data contributed, unfortunately, to Arbeitersept. This is due to the financing of our register. And we have no data delivered on ABA, despite the fact we have many data of these two compounds. But it was not possible to contribute to this register because they are not a whole class. So we can see here the adjusted CDAI remission rates at month 12 for all 14 registers, and it's very similar as we have seen on the picture before. The same is here for the individual treatment data and the CDAI information during the follow-up by country and by treatment. Very good data and all really very comparable concerning efficacy. You see here, Germany, no other data, unfortunately. And now we come to the most important slide of this publication. This is the multivariate Cox model of the drug discontinuation in patients from the 16 registers with individual treatment course level data. There was an adjustment made for age, gender, disease duration, seropositivity, number of previous treatments, concomitant treatments with CFD-MADs, concomitant treatments with glucocorticoids, very important point, which we see later from our rabbit data, CRP, HAK, CDAI, other comorbidities, smoking and BMI, and also stratified by country and year of treatment initiation, which is not a very, very long period because the JAK started, for instance, in Germany in 2017. So what we can see here, and this is a little bit different, and I would like to discuss this with you later in the discussion, it is very comparable concerning efficacy because drug discontinuation, I think, is a very good measure for drug discontinuation. And it is not as different as we have seen before. So this is really something we have to take into account, that the old is not bad, but the new is not worse. So again, here's some data on the hazard ratio of the discontinuation. And also, again, I have to mention that Germany did not provide data on IL-6 and also not on ABA. And there are other countries which also did not provide data. But you can see here, it is very comparable from country to country. There are not such big differences. Again, here you can see very nice on this enlarged slide, the hazard ratio of discontinuation by reason. And you can see here, especially concerning the IL-6 and also the JAK inhibitors, there were more discontinuations for, let me just go back again. For ABA, it was very well balanced. And you can see here data for JAK and IL-6, which are very interesting also for the discussion later for the reason of discontinuation. So to conclude this first publication, I can say that these results support the use of these 4 treatments for treating patients with rheumatoid arthritis, underscoring their similar effectiveness as assessed by comparable retention and response rates. The adjusted overall drug discontinuation and 1-year response rates of JAK inhibitors and IL-6 were similar to those observed with TNF, and that was the most addressed and interesting question. Compared with TNF, JAK were more often discontinued for adverse events and less for non-being effective, as were IL-6. All JAK inhibitors were grouped into one category. Potential differences were not explored concerning effectiveness among them, so it might be possible that individual JAK inhibitors have different effectiveness and safety profiles. So we cannot answer whether there are differences between the 4 available JAK inhibitors which we have out of this study. Considering similar effectiveness among these treatments, this study calls for the evaluation of other outcomes. It is my favorite topic, patient-reported outcome, and also other comorbidities, tolerability, safety, and last but not least, also cost effectiveness, which is planned for the future, as I heard in a very nice interview, also on Cytokine Signaling Forum from the original author, Tim Lauper, of this paper. So the next study I would like to present to you is a study with baricitinib. Here we see the 12-month results, and also it was measured the time to discontinuation, effectiveness, and patient-reported outcome from the European cohort. This publication has just been, it was data had been shown at EULA, but just some days ago it was accepted as a full publication, so you can also see it in the future. I can make a long story very short. The BeReal study is planned for 3 years, and now we have seen here the 12 months data, and compared were 2 groups, one cohort A, where the patients were treated at the discretion of the prescribing physician with baricitinib 2 or 4 milligram, and in the other group, the blue group as we called it, they were treated with biological or any other TSD mask. So the results are already available. We are at the end of collecting data. And as I explained already, the 2 different cohorts were assessed, started treatment with BARI or any other DMARD, normal inclusion criteria, only exclusion, simultaneous participation in any other study, a very, very simple design. So the recruitment was very rapid. And here you can see the key assessments, which we did in this study, of course, disease activity, swollen tender joints, and also pain, patients and physicians global, function, which is more and more important, as we have seen also from our rapid registry, and of course, quality of life measured by the EQ-5D. So here you can see the results. In the explanation or in the analysis of these data, we can see that the patients receiving baricitinib were older and had a longer disease duration at baseline than patients receiving the BO or TSD mask. And interestingly, as you can see here on the next slide, the most common reasons for discontinuation. Nevertheless, patients receiving baricitinib experienced low treatment discontinuation rates and were more likely to achieve remission than patients receiving the BO or TSD mask. You can see here the majority of the patients continued treatment at month 12. We have now already at hand the data for 24 months, and they are confirming these data which we have assessed after 1 year. Again, here the same data I mentioned already. And here you can see also the disease activity data, CDAI, swollen joint and tender joints. And again, also here the data on patients and physicians global, and also pain, which were really indeed more better and showing better results as we hoped and expected, but it was also the same true for function and for the EQ-5D. And this has been confirmed, and this is very important, especially quality of life in the longer run when we analyze the data of the 2-year results, which will be followed by the 3-year results. So these are the conclusions. Patients receiving baricitinib were older and longer disease duration at baseline than patients receiving the BO or TSD mask treatment. Nevertheless, the patients receiving baricitinib experienced lower treatment discontinuation rates and were more likely to achieve remission than patients receiving the BO or TSD masks. So the summary, I can say that 27% of the patients in the BARI cohort discontinued, while nearly 50% in the other treatment group, the BO or TSD mask, discontinued the treatment. So discontinuation, as we have seen already in the JAK study, is a very good measure for effectiveness, but somehow also for the safety measure, for safety alert in indirect method. So the third part of my talk is the risk of cardiovascular events under gynose kinase inhibitors in patients with rheumatoid arthritis. These were observational data from the German rapid register. And you can see here the objective. We wanted to analyze major cardiovascular events, MACE, under treatment with JAK inhibitors, TNF inhibitors, or conventional synthetic disease-modifying antirheumatic drugs in patients with rheumatoid arthritis in daily normal care. All known, the German register RABBIT is a prospective longitudinal follow-up cohort of RA patients. We started already in 2001. And here we have taken a selection of patients with treatment episodes between 2017 and 2021 on JAK inhibitors, TNF treatment, or CS-DMARDs, which were bio-naive. We measured the incidence rates of MACE, where 100 patient years, with a 95% confidence interval, and adjusted the risk ratios by Poisson regression analysis. And also a very important point, not only adjustment for age, sex, smoking, prior therapies, disease activity index by CDAI, comorbidities, but very important glucocorticoids, which we will see in a minute. So here are the results, the flow chart of the patient selection. You can see here the enrolled patient were nearly 15,000 and our selection criteria were met here: age over 50, one or more cardiovascular risk factor, hypertension, coronary heart disease, diabetes, hyperlipoproteinemia, or current smoking. So we could select out of our cohort around 1,000 patients on JAK inhibitors, also around 1,200 patients on TNF, and 500 patients on conventional DMARDs. Here are the patient characteristics: longer disease activity, already a low reduction, a severe reduction of function, measured by our German measurement Funktionsfragebogen Hannover, which is comparable to the JAK, and also which you can see here, there is quite a bit of patients who have glucocorticoids over 10 milligram daily, which is not a good sign. So here on this slide, you can see the crude incident rates were 100 patient years. Comparison here, the data for Rabbit, for the JAK inhibitors on the right side of the panel, for the oral surveillance, and for the STAR RA study, recently also published. And if you go to the adjusted Poisson regression analysis, you can see again that the most important factors for our result were the comorbidities, and as I mentioned before already, the glucocorticoids. Very important that these factors, and here glucocorticoids equivalent to 10 milligram, really had made the risk much higher compared to all other factors. So to conclude, the incidence rate of MACE in our patients receiving JAK inhibitors was comparable to the TNFs. The incidence rate was lower than the rate reported in the oral surveillance study and in the STAR study. We have seen no evidence of an increased relative risk of MACE with JAK inhibitors compared to TNF when they are prescribed in daily rheumatological care. And that's a very important discussion point, I think. And the results are applicable to unselected RA patients and to selected patients according to randomized clinical trial criteria of the Rabbit cohort. It is very important. So real-world data have shown no increased relative risk with the JAK inhibitors. And I think this is already due to the very good selection by the German rheumatologist. I'm at the end of my presentation, and I would thank you very much for the attention.
Fantastic. Thank you, Rieke, for that wonderful talk. And in fact, if I can invite Chris back onto the panel, we have questions already trying to discuss and compare what you have presented, the real world data on cardiovascular event and oral surveillance. So the first question is from Edgar Steimner. He said, thanks a lot for the excellent talk. How to argue if one say that in oral surveillance, a strong cardioprotective treatment, anti-TNF, has been tested versus a less cardioprotective one? And why can the OS data not be reproduced in registry data? In fact, in the Rabbit study, Rieke, you've just confirmed that observation. So why are we not seeing the similar data from oral surveillance?
Questions to Chris or to me?
I think both of you should have a chance to answer.
Yeah. Chris, make a start. I will follow.
I'll make a start. I think it's difficult to know certain. I've heard various explanations. In fact, Professor Alten just mentioned one of those, which is, of course, in the registry data, in some of the big databases, the real world data, clinicians are already making decisions about who they treat. And therefore they're altering, and they were already perhaps altering who they gave JAK inhibitors to. I mean, that's possible. And maybe even when we were thinking about the possibility of VTE being a risk, we started selecting out a group of patients. So that's one of the things. The other thing that's in question, which I think is really important, it's relative risk, isn't it? It's relative against TNF inhibitors. And it might turn out that TNF inhibitors are just really good at reducing the cardiovascular risk. And that's clearly important, but that may become more important in a particular high risk group where you want to reduce that inflammatory burden on cardiovascular disease versus other populations as well. And then the last thing is we're going to have other data, aren't we? We've got to wait a couple of years, but baricitinib is going to have similar data to oral surveillance. When I say similar, I don't know what the result is, but similar in terms of the design of the study. And that's going to help us to be informed.
Hey, great. Rieke.
Actually, that's very important to have these data, but I think we have to wait 2 or 3 more years to get these data, and these data will also be very important for the agencies. Unfortunately, as far as I understood, the agencies never rely on registers. They don't take register data for their decisions, at least the EMA, I know this. And what you mentioned, Chris, actually, I think we did not think concerning risk factors with JAK inhibitors only after oral surveillance. We did talk about this already before, because we knew that the risk of venous thromboembolism was there. That was not a new thing after oral surveillance. But what we forgot a little bit, I remember that there were warnings with TNF that you couldn't give TNF inhibitors to New York Heart 3 or something like this. It's more than 10 years ago. There was a big black warning on the TNFs. But actually, I think the paradigm shift, which we now have really to understand and to perform, is that there might be indeed a protective effect of TNFs, which we didn't know so far. And it has really clearly to be shown, I think. And this is not the reason why we can say the TNFs are the good guys and the JAKs are the bad guys. I'm not willing to blame them, because for many of my patients, it is really a big advantage not to self-inject. You really to have an oral compound. We never have to forget this. And if we do a very, very careful patient selection, and if you go to the data from the jackpot study, efficacy is very good. And safety, as you said also, Chris, has to be balanced. And this is really the highest duty of the rheumatologist, to select the right patient for this wonderful treatment.
Yes, that is great. Maybe I can just chime in with a point, if I may. What was always interesting is that in 2018, we published the MACE event in Wales of all our IRA patients, and our incidence rates of MACE event was very similar to the tofacitinib arms in oral surveillance. So the TNF treated group was definitely have lower MACE event than we observe in the whole population. And given oral surveillance is supposed to be enriched with patients at higher cardiovascular risk, I'm not seeing, compared with the whole population, an increase in cardiovascular event. But one thing that you highlighted from the jackpot study, and it only came to me when I listened to your talk, Rieke, was that you show that maintenance on treatment with the Janus kinase inhibitor and IL-6 inhibitor was definitely better than TNF inhibitor. And that has also been observed in the pan-European registry, TOSERA, with IL-6 inhibitor compared with TNF. And I always explain to my student that one explanation is not necessarily a comparison of efficacy, but because IL-6 and JAK inhibitors are much better as monotherapy. And we know that compliance with methotrexate in real-world data is pretty poor. We may prescribe it, but doesn't mean that patients are taking it. So effectiveness may actually assess adherence to methotrexate in a TNF group being really poor, and the patient were actually taking TNF inhibitor as monotherapy in real practice. But we also know that methotrexate is cardioprotective. There's really strong evidence about that. And so one potential reason why we are seeing greater cardioprotection in the TNF methotrexate group in oral surveillance is because in the clinical trials, people take medications better than in real world. In real world, people don't adhere to the medication as good as we expect them to be. So I think that's
especially not to methotrexate. Some years ago, we made a big survey, 6,000 patients, and the result of this big survey was the patient wanted an oral compound, and we said, oh, wonderful, we have oral compounds now. But then they said, yes, but this oral compound must never, ever be methotrexate. And if you follow up your patients and they say the truth, and you ask them, I think you need a new prescription, they say, no, still I have tablets or whatever they have. That is really a lot of not taking methotrexate, because people hate it. They have a bad day the day after or the day they take methotrexate.
Okay.
Ernest, I was just going to chime in around just thinking about how nice discontinuation rate is as a measure. And I think that's already been highlighted, but it's the fact that it's a combination of efficacy and tolerability and availability and adverse events. And, it's everything in a dirty rolled into one real world endpoint. And so, I think it's a very useful thing to use. So that's one of the great things about the real world data, is seeing the discontinuation rates.
Okay, so
it's a great endpoint. I think it's really a complex endpoint. It says more than only what it should say, could say.
Absolutely.
I just want to take this point in encouraging people to ask questions to our two very eminent speakers. But there is a question from another attendees who, again, similar, want to ask a question about how to compare oral surveillance with real world data with JAK inhibitors. We kind of started discussion on that, but maybe Chris and Rieke, you can take this opportunity to, again, contrast and compare the difference between what is a safety event-driven trial with real-world observational study. What are the subtle differences between the two kind of study design?
Yeah, I mean, I think we've looked at some of this already, and we've looked at the biases that can creep into the observational data compared to a study like this. I mean, you have to say that a designed randomized study like this is of good quality. You can't ignore the data from oral surveillance. I've also seen people break it down into different bits to try and see where is the risk population, and particularly the risk population was, I think, that the US population included rather than the European. So there are subtleties within subtleties about where this risk is being driven. I mean, the bit that I'd really like to know is, yes, but why? What is the effect of the TNF inhibitor in reducing it? Why does it reduce it in some people but not others? Why with the JAK inhibitor, with tofacitinib, is that not happening? So it also asks a lot of questions that I think I certainly don't know the answer to. But I think we've touched on some of those things already. And further sub-analysis, there was some at EULAR, wasn't there, of the different populations that were being shown to try and work out where the risk is. And then what it tells us in the future about how inflammation affects cardiovascular risk, how it leads onto a greater understanding beyond rheumatology into inflammation and cardiovascular disease as well.
Rieke?
Actually, one point which really I did not like at all in the oral surveillance study was the fact that they started with 10 milligram 2 times per day. And that was really another confounding factor. We know from the very early beginning, when we studied oral solo or whatsoever in the early phase of TOFA studies, that 2 times 10 milligram BID is not good for the patients. We saw a lot of side effects, and this made the study really, we say in German, Gemengelage, you know what I mean? This is too much facts, and also in this study, the inferiority, to my understanding, was not defined really exactly as it should be. And I don't know why they did this in this way, but they are really having a goal in their, an own goal, again and again. And so we do not get clear answers from the study. There might be signs, which we can really take very seriously. And another fact are also the malignancies. Is there a risk for malignancies by the JAK inhibitors? I don't think so. But is there a protective factor? And there were many patients with pulmonary, with smokers, and with the risk of developing pulmonary tumors. So all these factors intermingling. So for me, it's very, very, I'm not able to draw a clear conclusion. It's inconclusive. Sorry, I have to say so.
Okay, maybe I can just add a couple of generic points about real world study versus this kind of safety randomized control study. So if you look very carefully at the patient characteristic, for example, in real world study, age of patient tend to be a lot younger in the JAK study. So what Rieke showed with the rabbit registry was that the average age was actually younger than the oral surveillance study, and she did an enriched analysis in order to match the risk. So that's why in real world data, the event rates are actually lower than what they observe in oral surveillance. It was designed to get enough event for the comparison. The second thing in randomized control trial is that not only adherence is better because patients are encouraged, and we count sort of tablet returns to encourage adherence. Real world data won't do that. Is that adherence to drug monitoring and therefore treatment of comorbidity is likely to be better, because researchers who are enrolling patients are more likely to treat to target. In real world study, we know that actually treat to target are less readily achieved because the monitoring is not as tight. So for example, if you have hyperlipidemia as an outcome in randomized control trial, this will be picked up, and the clinicians are likely to treat the hyperlipidemia. In real world, adherence to those kind of monitoring are not likely to be as good. We know that from many studies. So one has to be a little bit careful when we compare those treatment. Real world study really reflect the complexity and the heterogeneity in clinical practice. In the clinical trial setting, patients are monitored a lot tighter, and they're likely to be followed up according to a very tight protocol. So those are subtle differences that can affect the rate. And I think if you look at the use of corticosteroid, the dosage use, they're all very different between oral surveillance and the real world study. And those can make a difference. As Rieke already showed, steroid dosage was a factor in the rabbit registry in cardiovascular event. So, so I hope I just contribute a little bit in terms of the methodological difference between those studies.
Yeah, and it raises another thing, just thinking about the glucocorticoids in this. Okay, so one of the other areas of difference between the ACR and the EULAR recommendations guidelines is around corticosteroids, with the US being much more, let's not use them, and EULAR being much more, they seem to have efficacy, and in studies where you bring people off steroids, they usually do. So it shouldn't be a problem continuing in the longer term. But it does raise the question whether, if we think JAK inhibitors might be increasing cardiovascular risk, whether we should be pushing harder to reduce steroids in that group that are on JAK inhibitors. And I just wondered what both of you thought. And it brings out, that fascinating area between ACR and EULAR where there's this difference. And where there's difference, there is always lots of productive
But
thinking.
for the first time, also the EULAR is a little bit clearer. Now they say really the glucocorticoid should be reduced and stopped as soon as possible, as our German recommendations say already for 2 years, stop after month 6. But if you go to real world data, it is all over the place, not true.
Yeah, actually, that is a really good point to lead on to a question from Ricardo Xavier. He asked the question, is there any explanation for the higher risk observed in the TNF versus the tocilizumab? There's a cardiovascular study, pretty similar in design, looking at MACE event, comparing TNF inhibitors with tocilizumab. And in that study, it didn't show increased risk with tocilizumab versus TNF inhibitors. Why would we see that and not see that in oral surveillance?
Yeah, I mean, interesting.
It was Sumacta, or which one was it?
Yeah,
was it Sumacta?
No.
I think so.
What is that? I can't remember the acronym for the study, but this is the cardiovascular outcome study comparing TNF.
Yeah, I remember.
Tocilizumab. I think the odds ratio was 1.03 in that study, so there was no difference between the two treatments.
And of course, you could use that as evidence that whatever, if JAK inhibitors are increasing MACE events or not reducing them as much as TNF inhibitors are, then if the tocilizumab study is comparable, I'm getting caught between my toffees and my talkies, excuse me, then it might say that IL-6 is not the mechanism. It's not the thing that's causing that difference with JAK inhibitors. And certainly in discussions around the EULAR recommendations, that was used as evidence to raise that as a possibility.
Yeah,
right.
Or you can turn that upside down and say that TNF and IL-6 are more directly causing cardiovascular events, and therefore inhibiting this cytokine have a more substantial cardiovascular reduction effect than a general reduction in inflammation via JAK inhibition.
Yeah. Ricardo's helped us out. It's Entract, the study. Can you say?
Entracta.
Of course, it's Entract.
Yeah.
Thank you, Ricardo.
But Entracta, yes.
Yeah.
Okay, so I hope that was a helpful discussion in terms of mechanism. I guess one thing we did say is that one of the things that we with IL-6 inhibitor too is that because of the risk of GI perforation, we always try to reduce steroid as soon as possible, don't we? With IL-6 inhibitor. But I guess now the EULAR guidance just said that we should be doing it anyway.
Yeah, absolutely. Yeah.
Okay, I think we have no other open questions. Maybe we have exhausted the discussion already. So I want to thank Chris and Rieke for a wonderful talk and wonderful discussion. I think this is helpful for all of us to think through how we may want to use Janus kinase inhibitor. And I think it reflects different approach, different thinking, and open up new questions to help us in everyday practice. So before we finish, we want to not only thank all of you for attending. There is a short evaluation form. I like to encourage all of you to give us some feedback so that we can improve future ForumLIVE meeting. And the last slide is to highlight to you and a bit of advertising on the next ForumLIVE meeting, which is going to be about targeting the Bruton kinase in rheumatic diseases, which will be held on Wednesday, the 2nd of November, at the same time as today's meeting. And the QR code at the bottom of this slide will help you to register for that forum. So thank you again for attending this ForumLIVE meeting, and thank you again to Chris and Rieke to get us into a great discussion on the topic.